Hello, good evening everyone, and welcome to the Switched Oncology, the patient experience focus group on behalf of Havas Lynx. We're on the cusp of a revolution in oncology, in prevention, in diagnosis, and in treatment. Molecular oncology, immunotherapy and beyond are transforming knowledge and expertise. Science is shifting, perceptions are changing. But this isn't the final frontier, and to make a difference to the millions of people who face cancer every single day, we need to reposition the question, challenge the accepted certainties, and personalise the solution. We bring together the experts, the patients, the scientists, the technologists, and the creatives. We unite powerful insights to make science mean something real. We're stronger together. We're switched on. Welcome everybody. First of all, I'd like to introduce and get everybody to know who everybody is. So I'm going to begin by asking Phil over here just to introduce himself. Tell the rest of the panel a little bit about himself as well.
Hello everyone, my name is Phil Howells. I'm an advertising creative director. And the reason I'm here was that I was diagnosed with bowel cancer just before Christmas, operated on before Christmas. I had a colon resection, and 2.5 weeks later I got the all clear. That's the reason why I'm here.
Tremendous. Margie?
Hi, I'm Marge, and I guess the reason why I'm here was very similar to you. I was diagnosed 6 years ago around Christmas time with womb cancer, and then they found ovarian cancer as well at the age of 35. After a long journey around cancer and fertility issues and all sorts of things, I'm still here, and I've set myself up as a fertility navigator for women who are looking to go forward in their journey and around family planning. Excellent.
Purav.
Hi, I'm Purav. At the age of 33 in 2009, I was diagnosed with gastroesophageal cancer. I had 9 months of treatment at one of the leading London hospitals with a view to resection. And upon attempted resection, they discovered the growth was bigger than they'd realised. So closed me back up and said I was palliative only. 7 weeks later, from memory, I had, after a second opinion, numerous staging and scanning, life-saving surgery on Harley Street, and I'm here almost 8 years later.
Fantastic.
Amazing.
On to you, Katie, please.
Hi, I'm Katie. I am an account director at a creative agency. I was diagnosed with cervical cancer at the age of 29. I had fertility sparing surgery. So I had my lymph nodes removed and part of my cervix. I've now been given the all clear. It's been a year, almost to the day, and I've had the all clear from all my tests, so very pleased.
On to Lorraine, please.
Hi, I'm Lorraine. I work with Roy Castle Lung Cancer Foundation, and I've been involved for the last 6 years working with patients affected by lung cancer, and previously worked in breast cancer, so have spent 20 years trying to bridge the gap between the healthcare system and patient experience of cancer diagnosis and outcomes. And like many people listening and participating, have had family and personal experience of cancer as well.
Thank you very much. I'll explain briefly who I am. My name's Matt Eagles. I'm the head of patient engagement at Havas Lynx. Although I don't have any connections with cancer, I've actually had Parkinson's disease for 43 years now. I love communicating with patient groups and anything to do with communication in general. I think we should all be talking off the same hymn sheet so we can all understand each other, and hopefully there'll be better outcomes as a result for everybody.
Over to me.
Over to you, Vernon, please.
Thank you, Matt. So I'm Vernon Bainton. I'm Chief Medical Officer for Havas Lynx. I was a clinician that then moved out to the commercial world, working for one of the pharma companies in oncology, and from there moved rogue, shall we say, to consultancy and healthcare communications, having worked in oncology for about 13 or 14 years, so having seen lots of changes, or potential changes.
Stuart.
Hello, my name is Stuart Barber. I'm a policy advocacy and government affairs manager for a pharmaceutical company, Bristol Myers Squibb. I work in the area of immuno-oncology, but my background for 20 years is patient advocacy, working for a number of large cancer charities.
Next, we come to Dan.
Hi, I'm Di Cannon. I'm an independent businesswoman, but I work with Melanoma UK. That was following the death of my niece at 38. And I got involved with Melanoma UK purely for that, but also to try and kind of work behind the scenes to help the patient group grow. Melanoma UK is a particularly brilliant patient group as far as I'm concerned, but there's things that we need to do to make it easy for the patient. And that's really why I got involved, and I'm really humbled to be here tonight, so thank you.
Thank you. And finally, but by no means least, Mr. Dr. Ben.
My name is Ben Harmon-Jones. I am a medical advisor for Havas Lynx. I'm a clinician by training. I stepped out of practice about 18 months ago and have spent that time working with the oncology industry and communications. My real passion is improving the lives of patients, but also doctors and professionals with the new wave of innovative technologies that are coming. So that's what I'm passionate about.
Thank you very much. Now we're all introduced, we should go on to the first question to discuss, which is as follows. The scientific transformation of treatments are changing the view of cancer. No longer organ-specific, e.g. breast cancer, but more like my cancer, and it's being treated by my body. What we'd like to know, does this change how you perceive cancer? And so I'd like to ask this question, first of all, to Di, if you wouldn't mind, please. Have you got a view on this one?
Right, okay. Cancer in general, I mean, I'm here because of the melanoma side, but I think that my cancer side, we should make it a little bit simpler than what we've got, because it's cancer. Does it really matter what cancer it is? But we badge it into these groups. And for me, it is the treatment, the path, the contacts, the communication should be the same, I think, but we overcomplicate it. So I don't know whether that is pulling it to something you want to talk about, or...
It is, absolutely. Lorraine, what are your views, being an information expert as you are?
I think the aspiration that cancer is owned and managed by the person who has it is a worthwhile one. Yep. But it's not an experience that you can have without the support of healthcare professionals who understand the specifics of the disease. And I think, in all reality, coming from a lung cancer perspective, the idea that cancer is actually very far from the truth. Our view of cancer depends on where it is in our body, how important it is in terms of perception of the value it has on life impact and the people who experience that diagnosis. Is it something you can be loud and proud about, or is it something that you're made to feel ashamed about? And the reality is, in the UK today, there are very different reactions depending on where your cancer is still.
That is incredible. I think we better go on to somebody. Katie, what's your view? What do you think on this? I
completely agree with you, actually. I think it is dependent on where the cancer is, and I think how severe it is as well. I think when I was diagnosed, it wasn't something that I openly talked about. I wasn't embarrassed about it. I just didn't particularly want to talk about it, but I did only ever refer to it as being cervical cancer because that's what it was. And I was never really given a say in the way that was treated or anything. So
Interesting. Porav, what was your view? How do you see?
Well, I can only draw on my experience, so that's all I can really refer to, but I know that, and no disrespect to your view, but if cancer was just cancer, I wouldn't be here.
Sorry, I think that there's a misunderstanding there. For me, it was more about the way we talk about, for me, it's you've just said before you didn't really want to talk about it. But for me, it was more about we put people into the little silos and say, you know, we assume that they're going to want to either talk about it or we go at everything in the same way. Sometimes I think you should just give the cancer patient the choice of how they want to either talk about it or be involved with something. So I don't mean cancer is just cancer. What I mean is it's that kind of stigma that goes with it, and
there is definitely, I agree with that. There's definitely a stigma attached, but my mindset, I know from the moment I was told, I knew something was very badly wrong, was always, and whether it was right or wrong to think this way, it's grown from within me. Yep. So I can probably take care of it. At no point did I feel that it was going to get me. What made me feel horrible was the chemo, worse than anything. But there was, as a patient who didn't expect this at the age of 33, there wasn't enough communication, even from the professionals or from other patients. I was lucky enough to encounter one patient in the chemotherapy suite whose name and number I've still got, who was very gracious with his time, but there was no one to draw on in terms of experience. And in terms of that, yeah, communication is key. And people should lose a stigma.
I couldn't agree more. I couldn't agree more. With regards to the stigma and the communication of the cancer itself, Phil, you had an interesting form of, well, if cancer is interesting anyway, what was your experience with this? With the whole how did you feel about it?
How did I feel? Well, shock was probably the first feeling I had. It's like an explosion going on inside your head, that everything just decimates, and you kind of try and rebuild yourself when you hear that news. It was, yeah, a massive shock, and I had like you, I was positive about it. So I'd been on another drug anyway for an arthritic condition. So I'd been regularly tested for bloods. So I knew in my head, this might be naive, in my head though, it's not in my blood. So I was going through that process and I had a CAT scan. There wasn't anything in the CAT scan. So I felt quite positive about it in myself. But yeah, the feeling was unbelievable when you hear that news.
Ben, from a medical perspective, how do you feel about cancer actually being labelled as my cancer and my body as opposed to one cancer? How do you feel from a medical, do you think this helps the patients or does it help the doctor, the HCPs? What's your view on this?
I think it's very much in line with the views of professionals that are changing in terms of the technology that we have now in terms of classification of cancer being very much more nuanced and moving much more to a more sophisticated method of classifying cancer in terms of its molecular profile rather than just where it is in the body. It's always seemed a little bit bizarre to me that that's the way that we do classify cancer. And just picking up on a couple of the points that have been raised, it's always seemed a bizarre notion to me that every cancer is called cancer, that word, and I always liken it to the world of infectious disease, and it would be bizarre if you said I have an infection when you could have anything from a common cold to Ebola. Yet people still use the term cancer. But I think there is something interesting in terms of, again, the views that have been raised in terms of the word cancer and the things that people associate with that word, and what it means to people, and almost the identity that goes with it. And I think that's got a lot to do with, as we've said, the site that it's in. So I think we're at an interesting time professionally. There is a desire to move to a more complex system of classification, but there might be something in the identity of someone who is diagnosed with a breast cancer or a bowel cancer, something important in that we may, there may be something interesting and important in that we need to retain.
Stuart, do you want to come in there with a point? Yeah, I saw your finger going there.
I would. I think you know the fact that it's about your own personalised cancer. You know, we're at the forefront now of developments of new treatments, and as you say, the molecular biomarkers and the genetics. You know, that is going to determine, you know, which treatments are definitely going to work for you. And I think, you know, we're on the cusp now of, you know, far longer survival than we've ever had. And I think, you know, that brings up its own challenges for both patients and carers in terms of longer term survival, longer term side effects. So, it is getting around that short-term treatment to the long-term living with a condition, which I think is going to bring its own challenges.
Excellent. Vernon, Dr. Vernon, we haven't heard from you yet.
So I'm just going to pick up on a couple of those things, but we've got a number of patients here. Your immediate thoughts at that time are, this is going to kill me, right? Or it felt that way, certainly. That was the fear.
Yeah.
That's the fear and the concern. This was ultimately a death sentence. And picking up from the little I understand from you, Parav, you're still here. You didn't have standard care because somebody said you should just go home and have palliative care.
Yeah.
And Margie, as well, I'm perhaps going to ask you to chip in on the back of this, but you're here because of new techniques, new technologies, new approaches, and this also picks up with what you're saying, Stuart, about expectations and the potential for unlocking, the ability for us to unlock the potential of new interventions, new treatments, and have higher quality, longer term survival. And we feel like we're at that sort of cusp, but is it happening for everybody? And that's where I sort of have lots of questions from a communication perspective, from an access perspective, from an equitability perspective. And that's where I actually see bigger gaps appearing or potentially appearing. I don't know if you want to.
I think you're quite right there. I mean, I was in that room, and my surgeon told me in language that I didn't understand, and I was working for the NHS at the time. I'd been there for about 10 years. My husband's a doctor, and we just sat there in complete disbelief. It was not something that we were expecting to hear. We'd actually come to him to find out if we were kind of potentials for IVF. It wasn't. We were an infertile couple. We were trying to figure out whose fault it was, really. And we were given that information. The language that is two-tier. There's the language that I would use to describe what I had. So it's womb cancer, ovarian cancer. It was stage 1, but the professionals speak about it in another language which I cannot access, which patients cannot access. So coming back to that, my cancer, my body, I think that's very important. It is important to take it on. If you're going to fight it, you have to take it on. And coming back to that access, we didn't really have anything. I didn't go through anything sort of swanky and new, but we did do we had access to a network of people who knew who had more experience in a young woman who hasn't had children yet, was looking to have children, and facing this kind of gynecological cancer, and that was all in the States. So, and it was over Christmas, and so we spent our time just emailing people in Chicago hospitals, or sort of on the West Coast or wherever, just sort of figuring out what case studies they had and what we could do, and that was it. But I don't know whether Jane blogs would have that. Even I think for us, we were just stalled still, or me, I was still stalled at that room, that surgical room, where I'd been told, sort of a few days before, that I had cancer. It was because of my husband sort of pushing, and he put his doctor hat quite quickly on. But yeah, it's not difficult. The technology is there to do so. You can send an email, you can get on social media and find this information out. I'm very sure, but it's whether that language and that awareness and that accessibility is opened up to people.
Do you think poor communication then would actually create a mistrust between yourself and the healthcare professional if you weren't speaking in the same language at the same level? Do you think that creates a level of distrust?
I'm just generally, it may well be why things creep into. I mean, as doctors, you can probably say, you know, people will go on the Google and find out all sorts of wacky stuff. So, because that language it's not being understood properly at the point that it needed to be. Perhaps, yeah.
Paurav, did you actually find that you wanted to understand everything that was going on? Was the communication change very good with you?
It's just as a background to coming here, I reread every consultant letter that I'd ever gone through from 2009, from the moment of diagnosis, to remind myself, and I was quite shocked, having reread them in the last week, as to the things I'd missed. And honestly, no. I'm quite an inquisitive person.
Yep.
Very internet savvy. But honestly, as Marge hinted, as an average Joe blogs, you think the doctors are godlike status.
Yeah.
You trust them.
Yeah, of course.
They're in the job of saving lives. Looking back on it, I could pin multiple flaws in the whole mindset of the way I was treated. And the difference in treatment that I had part 1 to part 2, the whole mood was different. There was a positivity when I went for my second opinion from the oncologist, and what can be done attitude, rather than what now looks like in hindsight a ticking the box exercise from the first set of specialists, which kind of really shocks me. And access is not possible for everyone. I definitely believe that.
Phil, you told me an interesting story off camera about the fact that the nurses that were looking after you tried to dissuade you from being angry at cancer.
Yes. No, that was interesting, because part of my way of handling it was to be angry. I'm naturally very competitive, and anger plays a part in that, and and I felt comfortable being angry at it. And I had a session with one of the nurses. I can't remember if she's a Macmillan nurse or not now, but it was almost as if she was trying to break me. So to kind of get me to cry, to get it out of me. But I was happy with where I was with it. And I found that I didn't like it. I'm quite upset about it, actually.
I bet. Lorraine, you're nodding. I obviously agree with Phil. Is it something you've happened to patients that you know? Or?
Yeah, I think there's a real concern that what we think is there is a right way to cope and a right way to manage your relationship with your cancer. And actually, as varied as cancer is, are the ways of coping. And, you know, as I say, I spent 20 years in the field. I've met a lot of people who are really offended by the battling and surviving, and am I brave, and if I have the right attitude it'll all be hunky-dory. This is a lousy illness. And whatever gets you through, and you don't change your coping strategies overnight. And I think it comes from a genuine attempt to do the right thing in a difficult situation. But healthcare professionals are equally challenged. In lung cancer, we know that the majority of people at point of diagnosis have stage 4 disease. It's metastatic, it's not going to be curable.
Right.
And managing those kind of conversations where what you're doing is fulfilling someone's worst ever expectations. So I think I wouldn't underestimate the skills it takes for a healthcare professional to tell anyone they have cancer, however early stage. It's a traumatizing experience, but generalizing that there's a right way to deal with it is very naive.
Thank you. I'll ask Vernon about this, about the communication aspect, because that's something you're very big on, isn't it? You're very keen to sort of express opinions on this.
I mean, absolutely. That whole fight the war on cancer, right? 1960s, male-dominated political derivative language that victimises people that have end-of-life care and palliative care, and choose that those that fall on the way, that haven't fought hard enough. It's not inclusive. Many women talk about it being very masculine, male-dominated language. We've got genomics coming through. And what I see, spending my time working with clinicians, the experts are getting to know more and more and more and more. But the day-to-day the day-to-day oncologists, or their MDT, the multidisciplinary team that surrounds them, and let alone primary care, where there's a massive gap growing in terms of not just information transfer, but applying that information and doing things with it that's not fit for purpose. And the whole language, based on everything I've heard from patients, advocacy, clinicians, the whole language needs to be updated and be changed. Do we?
Can I just ask, as a patient, but taking the other side from what you say, as medical professionals, are you taught at all how to deliver the news, how to be empathetic? I mean, presumably you've had years and years of excellent medical training as to how to fight the diseases, but I'm sure no one's teaching you how to deliver it. And do you have the time to communicate effectively with each patient and empathise with them and get to know their individual needs?
So empathy and care. I mean, so there's two things. One is just about technical facts and decision making, and then there's the other side, which is the human, that softer skill set. And if I just tackle those two things, yes, we're supposed to be taught them in school, but medical education and the curricula of medical schools, the use of congresses, hasn't changed for hundreds of years, decades and decades and decades, right? I think there is a paucity of the right information and education needing to be rebooted as well and changed to help people. So confidence is a really important thing, right, for people to embrace new. How do we accelerate? How do we safely and rapidly accelerate confident adoption of things? And that's really hard in the constructs that we've got within medicine.
Yeah. I almost envy your position, being on the other side of it, having to receive the news. It can't be easy for you, and you must become robotic at some point, having to tell patient after patient after patient that you've got this, you've got that.
But I think, but going back to that, one is the other aspect about those softer skills and the empathy side of things, and we often turn to the clinical nurse specialists or talk to them about being really close to the patients.
Yeah.
And I think that's one set of emotional needs.
Yep.
So before this, we did a survey with Stupid Cancer. I don't know if you know the Stupid Cancer group, but they're a young adult advocacy group in the US. And they take a consumer approach to oncology and are very, very disruptive. Big network. And they say basically if you weren't an old person who's expected to get cancer or a young person with leukemia, we're basically left on our own. And we put a survey to them and we just asked them a question and we were talking about emotional needs and that 80% of people with of the patients, and it was vastly, it was 90% were cancer patients, said they had an emotional and or mental health need, and less than 50% of them, less than half of them got any, and a third of those that did said it was rubbish, not fit for purpose. So going back to that emotional need is
I'm not saying it has to be soft and cuddly and
no,
understanding each patient's needs, right? As you say, it's a coping mechanism. I was like you, angry, but I was just angry in my own little head and lashing out at people around me. But I think looking back, the chemo drugs probably made me even angrier and more miserable than anything else, and not capable of rational thought the whole time. And prone to outbursts. But ironically, the best communication I had two surgeons I encountered in both stages of treatment who were from what I understand, surgeons are the bluntest individuals on earth. But I kind of like that. You're telling me the facts, black and white. I now understand exactly what the options are. There is no...
I think there has to be a real consideration.
It has to be blunt.
Yeah, and not every patient is the same. And also within their disease, they will go through different stages, and the type of information you need at one point is different. So even day to day, I mean, I don't know about, to answer your question about training on how to deliver that news. Don't know about you, Venom. I was.
Right.
I was trained on how to lead someone down that staircase, was the model I was taught. Some people want to go fast. Some people want to be held by the hand step by step, and everyone is different. And the skill of that is recognising who wants to be led and who wants to run down the stairs. The reason that I had that training is because I went to an incredibly progressive medical school, and I'm very grateful of that, but I don't think every doctor is trained in that. But I tell you what is interesting, and what is, even having had that training, there is still something fundamental that needs to shift in the doctor-patient relationship, and that is the feeling of control and the feeling of needing to be confident, especially with the new wave of new treatments that are coming, where we don't know what's going to happen. We don't know whether people are going to respond. That confidence piece is incredibly important, because again, I don't want to speak for you, Werner, but I've been trained to be confident, because that's part of the medicine. It's not just the medicine that I give. The medicine is also that I'm confident and you believe me because I'm a doctor, where that shouldn't be the case. And especially with the new group of treatments that are coming, where we don't know what's going to happen. People might not respond. People might get a fantastic response. People have to be okay with not knowing. And that is something that fundamentally doctors are trained out of almost. They're trained to convince people to believe in them. That's part of the medicine.
But for that confidence, I mean, you're saying that you're trained to be, but it sounds as if there's not anything really backing up that confidence sometimes. Are you trained as doctors to keep in touch with all of this new science that's coming? Is there a collaboration between medical and science?
Really
because there's a lot of really interesting stuff out there.
Yeah,
I mean, even
absolutely.
the clinical trials I was reading today, they've got shortage of volunteers, but there's loads of patients that are literally dying to get onto something that's might be sort of not evidence-based, but certainly might save their lives. How do you match those two up? I mean, are you trained to match those up?
So the answer to that is there is a massive divide. So the way that medicine works is it's evidence-based, but that's dependent on the trials. But our trials have a very skewed populations that aren't diverse. Accessing those trials and getting the right people onto those trials is very dependent on whether the clinicians are involved in the trials or not involved, or know about it. Yeah. So I read somewhere there are 9,000 publications in peer-reviewed publications per month.
Wow.
Across oncology.
Oh,
right.
Okay.
Now, how does somebody? So the experts are getting more and more expert, but how do you keep up with that if you've got a full-time job that actually is running, over time with your clinics? And how do you, so you have to rely on consensus, but actually the information and the data that we're now, it's exponential, and it really is exponential. But how do we filter that rapidly, safely? How do we move people through that quickly? Even the clinical trial development program, even the time it takes to do the trials, adaptive trials or different types of trials, early trials that give us enough confidence to be able to give different. All of these things need to change.
Can I ask, once again, as a complete medical novice, are the incentives there for doctors who've been in the role for 10, 15, 20 years to want to adapt and move forward?
That's a very good question.
Or are they happy operating within their box of comfort zones?
I think given our ages, you'd have to ask some of the older group, but if you look at the numbers of people retiring earlier than previously expected within the health system, that may, I think, help answer that question.
Stuart,
I think I agree, and I think you have got this wave of younger oncologists coming in that are more open to the way that treatments are changing. I think this kind of information and access it is, unfortunately, if you're treated at one of the big centres, you probably get a better service than if you're out in a general hospital whose doctor is probably an older doctor. I'm not saying that, but probably hasn't had that education. And I know as a company we do a lot around, we are doing a lot around trying to upskill communication skills from the patient perspective. So the clinician is coming from the point of the patient rather than the point of the clinician. And I think, that is working well. I think, there is still a challenge around how the NHS is not keeping pace with these new treatments, and that is coming from the top but at the bottom. And there are a lot of clinicians that don't know about these new treatments, and that has an impact on the patient, because I think, with the world of the internet, patients are becoming more savvy. But they are finding it quite challenging to get that message across with certain clinicians, and I think that needs to change.
On the back of that, sorry, did you want to say something, Lorraine? Please.
I was just going to say I think there is an issue about people having that full knowledge and being willing to keep themselves upskilled and be open-minded to what's coming in terms of innovation. But I think one of the positives is that we also have a healthcare system that is much more about monitoring and ensuring that those practicing are accountable. And if you like, there are more standards now about this is what it should be like. And certainly, again, within lung cancer, we've got an audit that says, right, this is the survival rate in hospital A. If you're in hospital G and you're 20% less 1 year survival, you've got a case to answer. So we don't have the old clinical fiefdoms and deference to the surgeon that means you can't question their practice. But that doesn't mean there isn't a lot to keep up with and a lot of change needed that is going to take longer than perhaps from a patient perspective you'd like.
Could I ask another question? Sorry, once again on that point.
Yeah.
That monitoring, are the patients aware? And are they given the choice of the survival rate in this hospital is not the best, you may want to try another hospital? Or are they in the dark?
Well, certainly we as a charity, on our website, we've got information which interprets the National Lung Cancer Audit in a way that's relatively patient-friendly. So you can go in and look at, well, if I'm being referred to Hospital G, how does it compare? I think that data is becoming more available. It still takes a lot of effort and energy at a point when you're potentially feeling quite vulnerable, and you want that relationship of trust. So it can feel, it's a leap of faith, if you like, to go back to your doctor and say, how are you doing? Are you good enough to treat me? But it is a conversation that's beginning to happen.
I agree with your second point, because once again, from my experience, I was a private patient all the way through. I never questioned who I was referred to at all, at any point, until I was written off. And just went with whoever they said, and it was based on where I lived. And just didn't question any of it, didn't look it up, didn't do anything, just went with the guys. And it was a whirlwind.
And what's amazing, I didn't even consider that, the actual rate at the hospital. I wanted to know what the survival rate was, full stop, but I didn't dig deeper. I should have.
Interestingly enough, when my niece was diagnosed with melanoma, 2013 when she died, 10 years prior to that, she got initially diagnosed and was given the all clear 3 years in. So she never went back to get anything checked. And then 7 years later, she's stage 4. But again, she didn't question anything. So she had an oncologist who was absolutely adorable, lovely bedside manner, really related to her, but she didn't have the BRAF gene, so she got moved to another hospital. Loss of paperwork, completely different clinician, totally different attitude. It was literally like going into, remember Sainsbury's where you get a ticket to go to the counter and get your call next in, and I'm sat there thinking, this is just a completely different start. Who are we talking to? But because it was a well-known hospital for melanoma, you didn't question it. You said something before about going back over old notes. I've still got old notes from when she was ill. And God, I wish I'd have questioned things, because not doing a brain scan, doing a scan everywhere else, not a brain scan, and she's got brain mets. So it's those little triggers. And now people are getting more educated. But something I said before about, we do make it a little bit confusing. If the path of interaction was the same, or you could refer people instead. You go on every website now, it's just done in a different format. The information's the same-ish, but it just looks different. So which one do you like? Which one do you go to? And it is like being in a bit of a shop and saying, I like the look of that one, I'll take that one. And, you know, we've got to make it a little bit more simpler. I'm not medical. I can't even pronounce half the words that are in the melanoma drug arena. But make it simple for us and make it simple for the patients. You know, that's why patients come to the patient groups. We've got to try and act as the conduit for all the other information out there. And, you know, we're still learning ourselves.
I would totally agree with that. Moving on from that as well, and about the need for patients to speak or to understand what's going on, what is the general level of awareness of IO amongst patients, do you feel? And I'll open that to the floor if anybody wants to chip in. But I know, obviously, Purav, you a success story of IO, but were you aware of it before you got a second
So IO
opinion?
immunotherapy.
Yeah, correct.
To clarify, I've only commenced immunotherapy post my cure.
Right.
So immunotherapy didn't play a part in curing me at the time, but it's almost preventative now.
Right.
Touch wood, it seems to be working, but I was not given any awareness of it at all on my treatment journey. I think it was just too big to be effective at the time.
From a commercial point of view, Stuart, how do you feel IO is it well known? Is it the patients know about it? Do clinicians know enough about it?
I think, again, it goes back to where you practice, what hospital you're in.
Yeah.
And I think, you know, there is an understanding that this is out there, but I think the issue is a lot of clinicians haven't got the confidence because it does bring its side effects. So there's an issue there, you know, about the education. But I think, you know, from a patient perspective, I think, you know, Lorraine and especially you, because, you know, IO was in melanoma 5 years ago. So, you know, I think you probably can answer, you know, from your patient perspective, but I know that, you know, it has been in the media. And again, whether that has an impact on informing patients, I don't know. But again, you do have that issue of raising expectation because it doesn't work for everyone. But, you know, there is a lot to be done around educating patients about IO. And, you know, we work with the patient groups to actually make sure that they're kitted out with the right resources so that they then can answer the questions that those patients may have.
Absolutely. I mean, we've got a really strong group of social media active patients, more active than I've seen in a long time, but these guys know their stuff. They really, really do. The IO, it's, you know, well known in the melanoma arena. But again, it's that bit of when you get a newly diagnosed patient coming in, they're overwhelmed by this group of people who know it all. And actually they're maybe a little bit afraid of asking questions and they don't want to be seen to be the one who doesn't know enough about it. So again, coming back to the voice, the message, how we talk about these things, it's got to be pitched at the right level of where the patient is at. You know, but yeah, we've got a strong base who understand what IO is. And
there's a lot to be done around, you know, this is a different class of treatment.
Yeah.
I think you do have a situation where a lot of patients are being treated with IO, they're going for the infusion, but they're in a chemo stream, so they still see it as a form of chemotherapy. Yeah. It's not, it's totally different, so there is a lot of education that needs to get out there. You know, and it's, you know, it's been in melanoma 5 years, but it's going to come to almost every cancer in the next 5 years. You know, there's a lot coming up. You know, and it's going to be certain patient groups, certain cancers where there hasn't been a new treatment for 10, 15 years.
I think the potential with immunotherapy is that you build that awareness about the idea that there's another form of treatment and it's different, and that's important from a patient point of view. I think, again, there's a communication and knowledge issue around understanding whether it's going to be suitable for me and what the chances are of it working. And these are all the kind of nuanced changes about how you have a communication in a healthcare setting, and how the doctor or the nurse or whoever talks to the patient, and what happens with carers as well, in terms of not being able to give certainty. So if it's right for me and if it works, what would it mean? If it isn't right for me and it doesn't work, then again, you don't want to be removing hope, because we do have, it's one innovative, exciting form of treatment, but it's not the only one. And again, the opportunity to offer treatment to people who might not be able to have any other kind of treatment is new and exciting. And it's just getting that balance between giving a bit of hope, but not being unrealistic.
Do you think the reason why the message is, I mean, it's getting out, but it's not getting out fast enough? Is it? Do you think there's a sort of looking at sort of bird's eye view of every health system that's out there in the world? They tend to be reactive, whereas anything proactive, sort of chemo, you chuck it in, you chuck it at a person. It comes from outside in, rather than immunotherapy where you're actually doing the work yourself. You're actually producing the cure. Is that something that's why it's an alien thing? People aren't really proactive about their health until it sort of slams them in their face, and you have to react.
Absolutely, but that also comes on to something else, which is about how we look after our nutrition, our bodies in general.
Yeah.
That is one of the biggest
bugbearers
of mine in the health environment, is when you are diagnosed with cancer. My sister has just gone through ovarian cancer, and it was literally not a dietitian, or we'll get you a dietitian. We're now 12 weeks post-op. Nothing. Don't give that information. And coming back to IO, your immune system, you've got to make sure it's fully functioning. So there's a real disjoint there about our general health. And when you are diagnosed with a cancer and there's IO available, what are you as a patient going to carry on doing? It's not just about the treatment, it's also about what you can do to help yourself.
If I can just pick up on the back of that. For time immemorial, if you had cancer, you either chopped it out, irradiated it, or gave chemotherapy and poisoned it. We're now, with immuno-oncology, but also with targeted therapies, we're moving into a stage of living with cancer. And some might have curative intent, but others might be a chronic disease state. One is living with cancer and taking treatment. And that completely changes the whole set of expectations. And Pirav, you were saying about chemotherapy and the side effects, because it's toxic, and that's why you get them. But the whole treatment expectation, what am I expecting to get out of this? Is it longer term survival, or is it better quality survival? And going back to the other question, when we talk about changing the system, it takes time and money and effort to innovate and change things. Are we even measuring what values most for patients? Are we measuring the value that these medicines or interventions might give to people in the right way? Because we were measuring them based on radiation, chemotherapy, or older ways of measuring things.
It's quite interesting that you're talking about patient stage, and a point that you just raised as well. Why not take it back a step and introduce the dietitians and the boosting of the immune system pre-diagnosis?
Before,
as a general health awareness, and maybe not have fast food outlets in the hospitals. And it's not just in this country. We had an unfortunate experience recently when my son was taken to emergency in Florida, and there was a Starbucks and a McDonald's, and that was it.
That is a massive contradiction, isn't it?
Yeah. So prevention is a really interesting one, isn't it? Prevention rather than cure, right? So what is it?
It actually only comes about when someone's diagnosed with an illness, all of a sudden, it doesn't even have to be cancer, then it's like, oh my God, what am I going to do to help myself? Well, actually, help yourself. Now, I do get on my soapbox a little bit about food and diet, and I think people go, oh God, here she goes again, but it's the general simple things, and you're absolutely right. How many times do you walk into a hospital and there's a Costa, a Star, all with the chunky, sugary things? So yeah.
But to be fair, I mean, I reached a stage in treatment without wishing to go too detailed where I couldn't eat. And I was offered sugary milkshakes or meal supplements, which was just full of processed rubbish. And at the time, you just take them because you want something in your body. No dietitian services or anything else, even as a private patient, until you go looking for it.
There's also another link, sorry, I'm not even about dietitians now, other people getting involved when you have been diagnosed with cancer. Psychologists, people who really need to hone into how you're dealing with this. I mean,
this is actually going to be my next question.
Sorry.
No, please carry on. This is exactly what we like.
It wasn't a plug, honest, was
no,
it?
No. We haven't planned this at all.
It's those things that, you know, you go to see your GP, they then refer you. You get, you know, I'm talking about melanoma. It gets cut out. You're then referred. You're on treatment, but psychologically, it's absolutely a killer in itself, because you go home, you're on your own. I was a carer, I mean, it bothered me, and I was a carer. God only knows what my niece was going through, and yet there's no help available, or you've got to go on a waiting list. So put your dietitian and your psychologist and anybody else, you know, ovarian cancer, sister's just had it, and they said, right, we're going to put you into a new gymnasium and we're going to give you some, okay, phone the number. There's a 12-week waiting list. And it's like, seriously? I said, just pay. Because again, it all comes down to cost, but that really affected it even worse than coming out of the operation. This is part of her recovery, and yet she couldn't. She wasn't important enough to get a space in that gymnasium. And that worked in a completely different way to her.
Was she able to get it if she paid for it?
So she could easily go and pay for it.
Katie, just moving on to you, because I feel we've left you out a little bit here this evening. Was there any support available for you for your mental well-being when you were diagnosed? Were you left to your own devices?
There was. I probably didn't feel like I really needed to explore it. I actually did the same as you. I was sat last night going through like all the bump that I was given. There was an overwhelming amount of information. You know, they gave me information on the stuff that I didn't need. Like I was going through booklets about chemotherapy, radiotherapy, and I didn't need any of that. And you know, I remember the day that I found out. I walked into the room and there was 3 nurses sat there, and they each had like piles of information about this big. So I was like, well, straight away, like I know it's not good news. There was actually quite a key breakdown in communication between the nurse and the surgeon, because the day that I found out, the nurse, you know, she talked me through everything. She gave me all of this information. She talked me through like the financial help that I could get, or, you know, different support groups available. She did actually say that the surgery that I needed was really quick and simple, and, you know, I'd probably need like 3 days off work, and, you know, it was a really quick recovery. And then when I went to see the surgeon, he was, you know, he just started going on about how much like the surgery that I needed, and how I needed part of my cervix removed. He was going to remove the lymph nodes from my pelvic area, and I was just sat there like, sorry, what?
Yeah.
You know, I was like, so how long am I going to need off work? And he was like, you know, 6 to 8 weeks if you're lucky. And I couldn't believe it that, you know, they'd sat in the same meeting and, you know, discussed my results with, you know, that nurse, that surgeon, and then in the space of 4 weeks, I was, you know, like the information, like the way that it was just, you know, delivered, and the key breakdown there was really, it was really upsetting actually, you know.
I bet it was.
That day was it was really difficult.
What about you then? It was do you have any help where you were concerned with regards to your mental well-being and your general health?
I had no, so I went through the NHS and I had no offer of counselling or anything. So I was facing infertility, menopause, you know, cancer, of course, you know, perhaps death or whatever. There were quite a few things that, and I think it's like that for most people who receive that kind of news. You're not just it's not just a pretty little box that you can put cancer in. There's all sorts of other crap that you have to sort of deal with at the same time. No, I wasn't. The short answer is no. I wasn't given any information.
There weren't any recommendations. I mean, I just took it onto myself and got a Headspace app, and I used that. The guy who does it had cancer, so that was really useful.
What's your view on this then, Lorraine?
I find it really distressing that
I would agree.
both the resource that's meant to be there in terms of often the role of the clinical nurse specialist, which is meant to be the key worker around psychological support, and we know they're not evenly available, but the discussion is not as explicit. Also, there are a plethora of reputable patient organisations, cancer organisations out there who are set up to provide and do a bit of the interpretation and emotional support, and they are just not routinely signposted to. And I find that really sad, having spent 20 years trying to help address that. But the other thing is that what we've done is, in some ways, science is something very tangible, and from a medical and a clinical point of view, if you can offer a treatment, you can offer a way of managing cancer. So we've medicalised cancer, which is a legitimate thing to do, it's a disease. But in doing so, we've ignored, as you said, that cancer doesn't come alone. It doesn't just impact on your physical well-being, it impacts on what you thought your life was going to be like, it impacts on fertility, work, relationships, prospects, all of that. And that psychological devastation is not routinely acknowledged.
I'm quite interested to hear your opinion on this, Ben, if I may, because as a clinician, how does this make you feel as a clinician seeing all this going on?
What the disconnect between being able to access the information?
Yes, exactly. Not the right information being given at the right time.
Yeah, there was something that was raised earlier about yourself and not being given the same information by two different individuals. It's clearly incredibly distressing. There's almost something that people fall back, when I say people I mean clinicians and doctors, fall back on almost being an autopilot. So, I mean, in terms of your experience, do you feel that nurse was perhaps, that person was perhaps on autopilot in terms of, you say they went in, they had a stack of leaflets, and do you feel that was maybe the case?
Yeah, quite possibly, actually.
Okay.
I think the way that she talked about it was, it was all very straightforward, and she had everything ready. She was like, there's some leaflets on these support groups. This is the financial information. This is some was like information on general cancer, cervical cancer.
Yeah, because that's interesting, because I wonder sometimes if there's a lot to get through, right, in that conversation, and there's different. So I'm speaking as a clinician now. There's certain things you have to fulfil in that conversation. You have to, if it's a diagnostic conversation, you have to break the diagnosis, which is emotionally difficult for the person doing it as well, which I think is often forgotten. You have to outline what the next steps are from a medical perspective. There's a lot of things that you need to. There's a long checklist of things you need to do. And I wonder sometimes if people get hung up on doing all the things that they know they have to do and almost ignore the elephant in the room, as it were. And, clearly, it's not just about what's medically going on. There's a heck of a lot that's going on outside that, and the whole emotional trauma that goes with the conversation that you're having with them needs to be addressed as well. And I just wonder sometimes as if clinicians have been trained into almost being blind to that, because we have medicalised cancer, and that is legitimate, but there's so much to get done in that short space of time, and in a time when the time with the patient, that precious time with the patient, is becoming smaller and smaller and smaller. Perhaps there is more pressure to follow that checklisted approach rather than actually addressing what the problem that person is facing.
Interesting enough, though, with your experience with all the booklets, when you get diagnosed, you cannot. There's the amount of information going through your head, and they get given all this other information that you're supposed to read through, and a lot of it may not be relevant to you, as you've touched on earlier on. That it should be just given to you bite size as you go along, so you can manage it and handle it, because there is so much stuff going through your head. It needs to be condensed.
That's also interesting about the checklists, what you were saying, because we get a lot of questions from patients on what to ask when they go to see their clinician, oncologist, and again, different levels of the diagnosis. And we help there, and it's through other patients going through that process. We will go in, patients will go in armed with their checklists and go through and tick, 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 because they're working through it methodically. Actually, maybe it should be the other way around. If you guys are working through a tick list, it should be the conversation to say, these are the things we're going to cover off over the period of however long, and then it's down to the patient then to know exactly what they're talking about, so nothing is missed, because you don't want to miss anything, but you actually don't know what it is you may miss until you walk out the room, because someone says, did you ask? Yeah. Did you ask? Yeah. And you go, oh no, well, I'll phone up, and then you can't get through to someone, then it's a 4-week wait, or wow. So, there might be just something there it's as simple as that, and you're working through a process then.
Another example of that was during my one is that I was lucky enough not to go through chemo, and during my ones they said, even if you get the all clear, you'll probably have chemo. And that was preying on my mind, even getting to that stage, and I was thinking, oh God, I've got to go through chemo. I've heard how terrible it is. But then I was lucky enough not to go through it. But I just, in my head, I said, I'm going to have chemo anyway, whatever happens.
Yeah. So the conversation, it clearly needs to be personalised. It comes back to something that you said earlier, Marge, about don't Google. And it's something that is very much, in my experience, very much the party line from doctors. Don't Google. And I almost think, how dare you? Yeah. How dare you say that? Because as someone Googling has a need, right? They have a need for information. And it comes back to what you were saying, Di, about someone goes into a consultation having specific needs. And if what you're talking about is completely removed from answering what those needs are, you may as well not bother. You may as well, you can give them the best medical information in the world, but fundamentally, if you're not answering what that person's needs are at that particular time, that's the best medicine you can give them.
Yeah. Exactly. And there's two sides to that as well, I sort of think. One is around that health literacy piece and what do they need to know, and moving them along carefully, and we're not actually providing people with what they need to know in that stepwise process. The other thing is about why do those doctors say don't Google it? Because it has to come from me, because it's credible, right? Yeah. Also, the service isn't there. Well, because you have to have it in my hospital because these are the people that I work with. Because this raises the question. So, the vast majority, 4 out of 5 people with cancer have emotional and/or mental health needs. But we know they don't have psychosocial or psychology or psychiatrists as part of the team in many, many environments. But there's other ways to get that access. Is it remote? Is it by signposting you to other services? Is it because they want to talk to patients like themselves to share the experience? Or do they need therapy?
And also caregivers.
Absolutely.
They're always in that role, whatever it is that you chuck them into, and it's
the support of the ear, the partner.
And they have no support, that's right. Yeah.
And I think we have that role of what is it to be the doctor in this relationship, and that's set from, historically it's set from the way that we work with roles, and it's not fit for the long-term purpose, is it?
It's interesting what you say about caregivers, because I was going to raise that point. The need in terms of psychological, emotional support, I don't think is, from my experience, as prevalent for the patient as it is for the primary caregiver. And in my case, I was very, very lucky that my wife organised, methodical, note-taking, asking all the questions, and had just lost her father's cancer as I was diagnosed. So dealing with a double whammy. Didn't crumble once. but got no sort of empathy, but almost like, how dare you question me type of looks from the clinicians. And she was on Google, all over it.
Yeah.
I didn't bother. I was just fighting the disease and the toxicity of chemo and just being angry. But second regimen of treatment, which was curative, the mindset is that it was positive, but also a lot more empathetic. And I must say here that Margie's husband was one of the clinicians who treated me and has a very positive and warm, engaging persona, and it was a complete change, and she suddenly felt like there were people she could talk to who were also medical experts. And it was a complete 180-degree turnaround in terms of the whole approach for her and from them.
I think that's very interesting what you raise about them. Why would somebody feel undermined because you're engaged, interested in getting information? And if it's a problem with the system and you haven't got access to the drug or the medicine or the intervention, then that's the problem with the system. But having engaged patients and having empowered, truly empowered family and carers is all about the focus of what's best for the patient, surely.
Who else is going to
Yeah.
care
Who's gonna
more
do
for
that?
the
Yeah.
patient than you know, your loved ones? Yeah.
I'm with your wife on this one, because there's a tipping point, I think, as you get through because you're running alongside the patient, and in this instance, my niece, she was shocked. So I went into, because don't forget, big family, you come out of that interview, and it's like, what did they say? And you're thinking, oh my God, if I don't give them the right information, it's going to come back on me. And then all of a sudden, Claire gets her own voice, and she's getting used to what's going on. And not that you become redundant as the carer, but you're not as needed because there's other things that they need then. And then other patients get involved. And it's quite interesting. She turned to me one day and said, I love you, you're my chemo buddy, you're this, you're that, but you're not going through what I'm going through. And she was right. And at that point then, it's then they need the patient group and the other patients that can support them and tell them what's going to happen kind of next. But, you know, she was all over Google after, but not at the first initial stage. She just couldn't cope with seeing death, dying, cancer, bump. But then I went into it, and it was just as IO was coming in, but sadly it wasn't. But yeah, the caregiver needs some emotional support, but we're not given anything like that. And
Well, just a voice.
yeah,
They need to be listened to and taken seriously.
and this is why the patient groups are so important.
Definitely.
In the States, they have something, patient advocate. I mean, for those people who aren't as lucky as us and have, you know, caregivers and loved ones. I mean, what happens to them? I mean, you know, but I don't know how that differs from, you know, from what does the patient advocate do in the States that we could possibly learn from over here? Can we put that kind of middle tier in? I don't know, but might be something to look at.
Jill, the chief exec of Melanoma UK. If someone hasn't got someone to take, she did it with Claire. I was away and I couldn't go with her, and her mum just couldn't cope with knowing that she had melanoma, and she went with them. Now, you know, you can't do it on every occasion, but when you've got a close connection with patients, when you're an advocate and you've got a patient group, you will do anything you possibly can for them. But yeah, the States, I think they've got kind of buddies. They've got a buddy to go in with you. I mean, we've got a great relationship with the skin cancer nurse specialists in the UK. Those to me are they are our voice, because where the oncologist or the clinician doesn't quite have that bedside manner that you want, the skin cancer nurses do. They've got that edge. They've just got something, and they talk to the patient in a completely different way.
Again, that's the capacity issue. You know.
It is, yeah.
Not every patient is lucky to have half an hour of CNS. You're lucky to get 15 minutes a week or something, so there's an issue there. So,
I mean,
you know, whether there is this...
You're right there. They put things in and say, right, you have like 20 minutes. And you're thinking, is that all my life's worth? 20, 30, and if you go over, you're going to push another patient back. And it just doesn't sit well, but yeah, you're right, it's capacity, I suppose.
But that 20 minutes, you're living with it 24/7.
But it's within that 20 minutes. What do you want to talk about? If you want to just talk about anything and nothing, talk about anything and nothing. But don't be kind of driving me down this route of saying, right, you've got 20 minutes, you need to talk about this now. Actually, no, I just want to sit and I want to talk about whatever I want to talk about. It's my time.
But how do we extend that? How do we improve that interaction? How do we extend it beyond that consultation potentially, or the opportunity to help people when they're not in front, those their MDT or...
Well, I think part of that is, I mean, we've talked about the pros and cons of Google, but the reality of our modern technology is actually there are ways of accessing information and support almost 24/7, almost globally. And clearly, depending on where you are personally and health-wise, it might be easier or more difficult. But we certainly see, we've got a very active online community. We have people phoning the helpline who will say, I found a research paper from America about this particular innovative treatment. Would it work for my mum? So people are using new technology as an empowerment tool. And I think it can transform the kind of relationships and conversations that happen, so you can use your 20 minutes for what you want and what needs to be done,
I mean, we were talking before about checklists, and I don't mean to be as methodical as the tick list, but if that works, then have it. But it's as though we're waiting for patients to ask us what they want instead of us saying, you know what, we've got like a bit of a toolkit to go into and choose what you want when the time is right for you. So, if you want to know what to ask, maybe you don't want to use it right now, but when you start getting your voice a little bit more and you feel a little bit more comfortable, these are the things that we would advise you to do. Now, we've got checklists, we give them out, but it's, again, are they the same? Are they uniformed? Are they unique to melanoma? Or are they just generally what you would ask if you've just been diagnosed with cancer? And it has to be at levels, not everyone's as well educated as someone who is at stage 4 and has gone through all that. They're just coming into this scary world of melanoma for us. But yeah, in this scary world of cancer, it can become really overwhelming.
Interestingly enough, I'd like to sort of do a bit of a summary now of what we've discussed. But I'd also like to go around the room and ask, before we finish actually, is what we would like everyone individually, what we'd like to see changing in the cancer world and in the oncology world. Personally, I'll start off from my point of view. I'd love to see better communication at a level that everybody can understand. If we go around the room, Lorraine, what would you like to, if you had to do one thing, I know there's plenty of things that we need to do and need doing. Is there one thing specific that stands out to you?
I think it would have to be to create a realistic level of hope in people at the time they have a cancer diagnosis, so that there are improving treatments, there are many different kinds of therapy becoming available, and that people should approach diagnosis with some hope that something can be done to make a difficult situation a bit better.
I like that a lot. Katie, finally for you, what do you feel is the main thing you'd like to see happen in this field?
I think I'd like to see them connecting patients better. I think for me at the time, I didn't know anyone else that was going through cervical cancer, but I would have loved to have spoken to another woman who was going through that, and like pre-surgery, post-surgery, even now, I think that's what was missing for me.
Parag, is there anything particular you'd like
You've
to see?
opened such a big can of worms for me. They're all over.
I should have done this far earlier in the evening, perhaps.
One thing,
If there's one thing that you had
honestly, I'd take it back a step before diagnosis and say better screening.
Yeah.
Because some of our rates of incidence for a developed nation, from the reading I've done, are the highest in the world. And countries like Japan and the US have much lower incidences because their screening is much, much better.
So screenings, Marge, what do you think?
Only one?
I want to give everybody an opportunity to have their own.
Of course,
See if we
of
can
course.
get a whole lot of different things. I'm sure we will.
I think the job of doctors, I would say that's because I'm married to one, I think the job of doctors is it's a hard one, and just as patients want access to better communication, I think just opening it up for doctors, to train them or whatever it takes to give them the resources to access, the clinical trials, the stuff that's going on out there in science world, and become more confident about using it and not getting in trouble to do that as well.
Phil, you very quickly.
I think
running short of time,
I think a respect and understanding of how the individual wants to handle their cancer.
Yeah. Ben?
I would love for everyone involved in cancer care to, for a moment, forget what their role is supposed to be.
Yeah.
I like the GP one, but I won't have that one.
You can't have them. That has to be completely different.
I would like to see the introduction of additional support from dietitian to psychology. That's something to support the patient.
Stuart?
I think an acceptance from all sides that patients increasingly want to be involved in their treatment, and they want to have a role in that decision-making process. So again, as a community, it's how best we can support those patients to make the right decision.
Vernon?
Okay, I'm going to go down the communication route on this one. So communications have changed fundamentally in what we do in life. Some really important things around banking, around and the tools, the technology, the services, they're there already. So whether you're a professional and it's the way you're consuming education or keeping up to date, or whether it's the patient and how you're accessing services, information, there's great stuff happening now. It's just not happening everywhere.
Yeah.
It's just share best practice.
Yeah.
Stop the agendas, the individual agendas, and actually share what's good. And that's we need to make change now, not try to wait or plan for years in advance. And there's great things happening. We know that. It's just surfacing them and actually implementing them.
Ladies and gentlemen, I'd like to thank you very much indeed for attending tonight. We are stronger together. We're switched on. Thank you.